So we're going to start a series of talks now on carotid revascularization. The first will be by Dr. Wesley Moore, who will give us an overview on what has CREST changed, and who better to give us this talk.
Thanks very much, Dr. Laird. I think most of you are aware of the CREST trial, but just let me point out that CREST is an acronym. It stands for Carotid Revascularization Endarterectomy versus Angioplasty Trial. There have been a number of prospective randomized trials looking at patients who are at average risk for revascularization. Most of these have been outside of the United States. They include the EVA-3S trial, which was a French trial dealing with symptomatic patients who are at average risk for revascularization. The SPACE trial, which took place in German-speaking countries, same rules, symptomatic patients, average risk. More recently, the international trial, or the so-called ICSS trial, again, average risk patients, symptomatic. And in fact, this is the largest symptomatic trial to date. And finally, the CREST trial, which is the American trial. And we're a little different here in that we included not only symptomatic patients, but also the asymptomatic patient. Now, up to this point, the EVA-3S, the SPACE trial, and the ICSS trial all uniformly demonstrated that carotid endarterectomy was superior to carotid artery stenting. And the question is, what about CREST? Well, the objectives of the talk that I'm going to present this afternoon are, first of all, I want to look at one of the international trials as a basis of comparison. And I've selected the most recent, which is the ICSS trial, and also, obviously, to present the CREST trial. We're going to do a critique of each of these trials. We're going to look at the differences and the similarities. And we're going to see, finally, if, in fact, CREST has changed anything. Now, the ICSS trial was published in The Lancet in February of 2010, 1 week before the CREST trial was presented at the International Stroke Conference. And so this was sort of hanging as a specter over the heads of those that were presenting the CREST trial at that meeting. In the international ICSS trial design was that it was a prospective randomized trial which compared CEA with CAS in symptomatic patients. 50 academic centers were involved, and these were taken from Europe, Australia, New Zealand, and Canada. And the primary outcome that was being reported in this first publication was a 120-day interim analysis of the primary endpoints, and the primary endpoints included death, stroke, or procedural myocardial infarction. The selection of the participants in the ICSS trial has been a subject of some criticism, and let me just spend a little time going over this with you. They divided their centers into two categories, what they called qualified centers and what they called supervised centers. Now, a qualified center had at least one surgeon who had done at least 50 carotid endarterectomies, an average 10 or more per year, and had at least one interventionist who had done 50 interventional cases, but only 10 of those needed to be carotid angioplasty and stenting. Now, if you failed to meet these criteria, but still wanted to participate in the trial, you then fell into the supervised center category, and proctors were appointed to oversee either carotid endarterectomy or stenting. And after 20 cases were done, and if the results were deemed to be acceptable, then they were allowed to go ahead and move into a qualified center and continue the randomization process. Now, what they found, and I'm not sure how well you can see this from the back of the room, but this is the stenting group, of which there are 853 patients. This is the endarterectomy group, 857 patients. Largest symptomatic trial to date, including CREST. And if they look at the aggregate of primary endpoints, including stroke, death, and procedural myocardial infarction, It was 8.5% combined event rate in the stent group, 5.2% in the endarterectomy group. That this difference was highly statistically significant with a p-value of less than 0.006, giving an odds ratio of 3.3 in favor of carotid endarterectomy. And as they sliced and diced it for all of these various other parameters, the same thing held true. Now, here's the Kaplan-Meier curves comparing the cumulative event rates. The blue line is the stenting group, the red line is the endarterectomy group, and you can see in the first one, any stroke, death, or procedural myocardial infarction, a big difference between the two in favor of carotid endarterectomy. Any stroke, the same thing. Any stroke and death, the same thing. Disabling stroke and death, the two are a little closer together, but the differences were still statistically significant in favor of endarterectomy. All-cause death, again, a little closer together. And finally, any stroke or procedural death. Essentially, all of these showing a very definite favorable comparison with carotid endarterectomy. Now, this is a whisker plot analysis. Everything to the right of the median favors carotid endarterectomy. Everything on the left favors stenting, and you can see the preponderance of the points fall to the right of that line. This is a meta-analysis looking at EVA3S space ICSS, and then finally the comparison or the meta-analysis of all three. The median is here. Anything to the right of the median favors endarterectomy, anything to the left favors stenting, and you can see that all of the points fall to the right. One other thing that the ICSS investigators did is that they took a subset and subjected these patients to pre- and post-procedure MR scans, not only to look for overt signs of stroke, but also to look at the incidence of silent brain infarction. Here's the bottom line. This is the carotid stenting group. This is the carotid endarterectomy group. In the MR, between the pre and the post-procedure, at least one new lesion, that is one new infarction, 50% of the patients undergoing angioplasty and stenting had a new lesion, compared with 17% for carotid endarterectomy. Now, they're not the first to have done this. There have been a number of non-randomized trials comparing pre- and post-procedure MRs, and all of these trials showed the same thing, and that is that there were far more silent brain infarcts following stenting than they were following endarterectomy. Well, let's go on to the CREST trial. This is just from the front page of the New England Journal publication, which was in July, was the July 1st issue in 2010. And the CREST trial design was a prospective randomized trial of symptomatic, it initially started out only as symptomatic, but because we were accruing patients so slowly, we decided we better add asymptomatics as well. So we've got both symptomatic and asymptomatic. Primary endpoints, once again, are death, stroke, and myocardial infarction. We had a long debate when we were designing the trial, and the thought was that one of the benefits of a less invasive procedure ought to be a lower incidence of MI, and therefore that should count to the benefit of that procedure or against endarterectomy if in fact there was a difference. And that was the rationale for including MI as one of the primary events. The trial was designed, initially we were to recruit 2,500 patients, and our statisticians told us that that would give us a 90% power to detect a 1.2% absolute treatment difference on an annual basis. Now, the lead-in phase of CREST is unique to this particular study. One of the things that we recognize, and again, the CREST trial was designed more than 10 years ago, and so there were not a lot of people out there with significant experience doing carotid angioplasty and stenting. So one of the things that we decided to do was to have a lead-in phase, during which time there would be specific training for the interventionists who did not have prior experience, and specifically they would be trained on the AccuLink, AccuNet systems, and they had to submit up to 20 lead-in cases per individual, and that was reviewed by the Interventional Management Committee, and if they did a good job on the lead-in phase, then and only then were they allowed to proceed with randomization. So we had very well vetted group of interventionists in this trial. The final randomization, carotid endarterectomy, 1,240 patients, carotid angioplasty and stenting, 1,262, total of 2,502. It was virtually half and half. 47% were asymptomatic, 53% were symptomatic, and this may turn out to be a problem. The median, the first report, we were allowed to publish the data when the last patient entered into the trial had at least 1 year of follow-up, and the median follow-up for the whole group was 2.5 years. There will be subsequent publications as we accrue longer intervals of follow-up. Now the bottom line, death, stroke, and MI, carotid endarterectomy, 4.5%, carotid angioplasty and stenting, 5.2%, no statistically significant difference between the two procedures. And that is a bottom line that has been well advertised. But wait a minute. Why are we doing carotid intervention to begin with? I thought we were doing it to primarily prevent stroke. So if we look at death and stroke as two endpoints of the three, here's what we find. In carotid endarterectomy, the aggregate death and stroke rate, 2.3%. The aggregate event rate for angioplasty and stenting, 4.4%, almost twice as many. And that difference, in fact, was statistically significant at 0.005. We then tried to break it down between asymptomatic and symptomatic, and I would submit to you that there is insufficient power to do this because it was really designed to be looked at in aggregate. But having done that, here's what we found. Death, stroke, and MI in the asymptomatic patients undergoing carotid endarterectomy, 3.6%, 3.5% for angioplasty and stenting, identical. However, if we look at the post-procedure stroke rate, 1.4% for endarterectomy, the lowest rate of peri-procedural stroke for endarterectomy reported to date, 2.5% for angioplasty and stenting. That is less than the 3% threshold that the American Heart Association has recommended, and the interventionists felt pretty good about that. But in fact, there's a trend toward a lower stroke rate in the asymptomatic patient, but that difference did not achieve statistical significance, probably because of low numbers. If we look at the symptomatic patients, again, the aggregate event rates, 5.4% in carotid endarterectomy, 6.7% for angioplasty and stenting, a trend toward a higher event rates, but no statistical difference between the two. However, if we drop down to stroke as a primary event, 3.2%, consider that when you compare it with NASIT, almost half of what was reported after endarterectomy in NASIT. So we've gotten a lot better doing carotid endarterectomy. 6% for carotid angioplasty and stenting, which was equal to the NASIT data, and that's what is often being used for comparison. That difference, in fact, was statistically significant at a p-value of 0.02. There's been a lot of discussion during this meeting, not only in terms of things like patency and outcome, but how do the patients feel about the results? Or are they walking better if we've done something to their legs? So we took the opportunity to do a quality of life analysis with using an SF-36 form and comparing patients who did have an event versus those that did not. And we looked at the physical component as well as the mental component. And from a patient's perspective, the worst thing that could happen to them was a major stroke. The next worst thing was a minor stroke, and MI actually overlapped the median. And after a year, MI was not regarded by patients as being very important. The other thing we found was that there was an age effect on outcome at the end of a 4-year interval. And anything above this line in blue, CEA is superior. Anything below the line, CIS is superior. And it turns out the younger patients do better with angioplasty, and older patients, contrary to what you might think, do better with endarterectomy. And that median, or that crossover point, is at around age 70, which from my perspective amounts to the majority of my patients. So what are the strengths of the ICSS trial? Well, the trial was the largest symptomatic trial, and a cohort was used to check for silent brain infarction post-procedure. The weaknesses were that there was a very poor selection process for participants and probably led to suboptimal CAS experience among the participants. There was lack of stringent criteria for defining an MI, and the use of embolic protection devices, which we felt were mandatory, were recommended but were not mandated in this trial. The CREST trial strengths were there was a very careful selection of the interventionists with a 2-stage evaluation including a lead-in phase. We included both symptomatic and asymptomatic patients, which probably more reflects the practice in the United States, and the results of both CA and CAS are the best reported to date in the literature. Now, the CREST trial weaknesses are that we didn't have pre- and post-procedure brain imaging, so we don't know what our incidence of silent brain infarction is, and that it was powered appropriately for the whole cohort of patients, but it's probably inadequately powered to select out symptomatic from asymptomatic. So the areas of agreement for symptomatic patients, the incidence of periprocedural death and stroke was twice as great with stenting as it was with endarterectomy, and patients over the age of 70 did better with endarterectomy. The areas of disagreement is that the MI rate after carotid endarterectomy was higher in CREST than it was in ICSS. So a few conclusions. First of all, if the objective of treating lesions of the carotid artery is to prevent death and disability from stroke, then you would have to agree that CEA wins over CAS, but it wins at the expense of an increased rate of non-fatal MI. And you have to ask, are there any reasons for this? Well, the obvious reason is one's getting an open operation and a general anesthetic, but there's one other reason that you might want to consider. All of the patients undergoing angioplasty and stenting were on dual antiplatelet therapy. The patients undergoing carotid endarterectomy were on aspirin alone, and that may have had some effect in terms of the difference in MI rate. From the patient's perspective, stroke is more important than and more disabling than an MI. And while the long-term effects on survival in patients who experienced non-fatal MI compared to those that did not in CREST is yet to be determined, but there's a lot of evidence in the literature to suggest that life expectancy in patients who have had an MI is considerably less than those who have not. So that's a ding against carotid endarterectomy. And finally, patients over the age of 70 do better with CEA. So to answer the question, what's CREST changed? Well, I'd have to say probably not a lot. We now know that carotid endarterectomy does better in reducing stroke risk, but it does so at the expense of a higher MI rate. We now know that patients over the age of 70 do better with CEA. We now know that in the hands of highly selected interventionists and qualified surgeons, the results of CEA and CAS in the United States are the best reported to date. and that the results of CAS are likely to improve with time and improvement in technology. And I would suggest to you that one of the areas that could be improved upon is using something other than a transfemoral approach to get to the lesion. When you use a transfemoral approach, you have to deal with a disadvantaged arch. And it may be that the older age population that has a higher event rate with CAS may do so because there's a higher incidence of type 3 arches and a higher incidence of plaque within the arch. So if you could bypass the arch and do a direct carotid stick, you might obviate all of those problems. And the challenge to carotid endarterectomy is to reduce the risk of MI, and I think we can do that with better medical management. Remember, when this started 11 years ago, statins were not a routine. Now everybody's on a statin, they're on a beta blocker or an ACE inhibitor, and maybe we ought to start using dual antiplatelet therapy on the patients in whom we do carotid endarterectomy. Thanks for your attention.